Hello and welcome to this very special Mental Health for All webinar. My name is Niall Boyce and I'm the editor of the Lancet Psychiatry. It's a real pleasure to work with United for Global Mental Health on this webinar series. Now, those of you who've been with us from the start will remember that this series began life with a specific focus on the COVID-19 pandemic and its effect on mental health. And for the two webinars which we have scheduled for this month, January, we are returning to this topic and we're bringing you the experts in the field to ask, where are we now and where are we going? So in this webinar, we're focusing on the research and evidence aspects of the pandemic and its impact on mental health. We'll be doing another webinar in 2 weeks' time, which will take a broader focus, including discussion of what the pandemic means for the provision and delivery of mental health services. Now, I'd like to extend a special welcome to those of you who are attending for the first time. The way that this works is that I will put 2 rounds of questions to our expert panel, and then we'll have time for questions from you, the audience. If you'd like to put those in the chat function of the GoToWebinar program, that would be fantastic. I'll pick out some questions and we'll have time for that, as I say, after the initial 2 rounds of questions. This whole thing will take around 45 minutes, and if you would like to tweet along, you can join the Twitter chat using the hashtag MH4All. Now, to introduce the people who you're really here to hear from, our expert panel. We're delighted to be joined by Ed Bullmore from Cambridge, Maxime Taquet from Oxford, Nisreen Alwan from Southampton, and my colleague at the Lancet Group, John McConnell, the editor of the Lancet Infectious Diseases. So I'd like to start by turning to Ed. Now, Ed, you don't need to be a hardcore biological psychiatrist to think that if something affects the brain, it will affect the mind, and this will affect mental health. What do we know about the direct effects of this virus on the brain?
Well, thanks, Niall. I mean, I think it's just worth saying that COVID hits mental health 2 ways, I think. It hits mental health through the social response, the pandemic response, lockdown, the economic consequences, and so on, which are going to have an impact at population level. And then it is likely to have effects on mental health through its effects on the brain, and that's going to be specifically in patients. And there's really no doubt that the virus has an impact on the brain. I mean, I think the most obvious example of that is loss of smell and loss of taste among the cardinal symptoms of COVID. But since April, there's been quite a lot of research ongoing that's pointed to higher risk of neurological and psychiatric complications in patients with acute COVID, and that's something that we're continuing to look into very actively.
So with that in mind, I'd like to just turn to Max now, because Max, you've looked at the broader picture about the effect of COVID on mental health. But how does the effect of this illness, which in some cases is very severe, differ from any other severe illness that might affect people?
I think the short answer is that by and large, the rate of psychiatric illnesses after COVID is significantly higher than after many of the other physical illnesses. The slightly longer answer to that is any medical illness can trigger or can precipitate potentially a psychiatric illness. And so the question is not really whether COVID-19 would cause or would lead to an increased rate of psychiatric illnesses, but whether that's the extent to which that's the case. And so to answer that question, we looked at a group of patients, 62,000 patients with COVID, and we looked in their health record for evidence of psychiatric illnesses in the 3 months after the COVID illness, and we compared that to other groups of patients that had different illnesses such as the flu, other respiratory tract infections, skin infections, but also gallstones, renal stones, etc. So a wealth of conditions. And what we found is that after the COVID illness, in the 3 months after illness, it's about just under 1 in 5 patients who would experience psychiatric illness. And for 1 in 4 of them, that's the first time that they would be diagnosed with a psychiatric illness. And that's about 50% higher to twice as high as what we would see in other groups of patients, the one I've mentioned before, so flu, other respiratory tract infection, etc. So it seems that COVID-19 is associated with significantly more psychiatric consequences, if we can put it that way, compared to a variety of other medical illnesses.
And of course, this will be a multifactorial thing. It will be based both on the direct effect of the virus on the brain, which Ed was talking about, and the general social effect, the fact that this is a novel virus, that it's a very frightening virus. How do you begin to untangle these effects?
Well, I think it's you're completely right. So there's sort of a psychological explanation to that and a biological consequences to that, biological explanation to that. Our data did not allow us to look very deep into that, but we can start sort of getting ideas. We can look at so one thing that we looked since our first paper was published is whether other illnesses that carry the same sort of stressful sort of factor that, you know, when people get it, they believe that they might die of it, or that it might at least be a very severe illness. So one interesting group of patients that we looked at are patients with pulmonary embolism. So that's a blood clotting into the lungs that affects the breathing, and that's a severe illness. And for many patients, that's quite serious, and it's life-threatening. And so we thought that it had the same sort of flavor in terms of the stress that it might cause. And what we found is that, again, COVID was leading to significantly higher rates of psychiatric illnesses compared to that group of patients as well. And that might point to the fact that there might be a biological element to it as well, as Ed Bullmore was just explaining.
Thanks, Max. Ed, you have something to add, I think.
Yeah, I was just going to sort of expand a little bit on, because if you tease out the social pandemic response and then the biological response, it's worth just bearing in mind the biological response itself could be multi-pronged. I mean, this is quite a damaging virus to the nervous system in lots of different ways. I mean, Maxime's already alluded to embolism, and we know that SARS-CoV infection changes the coagulability of the blood. It makes the blood more likely to clot, and we see a lot of stroke, particularly cerebrovascular strokes occurring in younger patients without obvious premorbid risk factors. That's one mechanism. You can shut off the blood supply to the brain. The other possibility is that you have brain effects as a result of the immune response to the virus. And we know that the immune response can be profound, and patients, many of them have massive sort of cytokine storms, innate immune response to infection. And we know from other studies that that kind of immune response and other forms of immune reaction to the virus can have adverse effects on the nervous system. And then the third possibility is that the virus gets into the brain. So you have blood flow, immune response, and brain infection, all as candidate mechanisms for a direct effect of the virus on the brain. And I think when this kicked off, more or less a year ago, it wasn't clear, of course, whether SARS-CoV-2 did in fact infect the brain, but evidence has since accumulated to suggest that it can. And we've seen examples of post-mortem studies reporting evidence of direct viral infection, and studies looking at cerebrospinal fluid sample from patients with COVID, indicating that there is viral material in that fluid, indicating probable infection of the meningeal membranes around and within the brain. So it's a complicated story, and it's not just the social biological split. Even within the biological dimension, there are these multiple candidate mechanisms by which the virus can cause injury to the brain and ultimately mental health and cognitive consequences as a result.
And this virus is always surprising us, and we had a particularly unpleasant surprise here in the UK, of course, last month with the emergence of this new strain. And I'd like to stay on that theme really by bringing in Nisreen and this issue of long COVID, so-called. Now, of course, this is something which I understand you have personal experience of, which is, well, perhaps you could describe it to us.
So yes, thank you so much. So the long COVID really is kind of an umbrella term to describe the unexplainable course of the illness experienced by people. So people who were a lot of long COVID, the first wave long COVID, obviously were like me, had the infection or experienced symptoms of the infection. Many of us, most of us actually didn't have access to the test if we weren't admitted to the hospital, but had kind of what we now recognize are the classical symptoms in March. April, and then there was this strange course of the virus, which you feel like you're almost recovering, and then it's fluctuating, almost relapsing, remitting nature really, and then and then you go back into the symptoms, having symptoms again. Some of the symptoms are the same and stay throughout, so that's for me and for other people. Some of them actually, very interestingly, the cognitive dysfunction symptoms that people are experiencing tend to appear a bit later in the illness. Some of them have at the start, but it seems to be a feature that, you know, a higher proportion of people with long COVID have them a bit later in the illness, and then they kind of largely become you know, a very prominent symptom, you know, or a collection of symptoms later. So what's the definition of long COVID really? There have been recently NICE /SIGN RCGP guidelines, and they define long COVID, or as they call it, post-COVID syndrome, as having a selection of signs and symptoms consistent with COVID-19 for over 12 weeks. And there's a bit in the middle between 4 to 12 weeks where they called it ongoing COVID-19 illness. But obviously, to an extent, the time cutoff is arbitrary, but anything beyond 4 weeks seems, you know, is considered long COVID, taking in mind this very, very prominent feature of fluctuation and relapse remission.
So my next question was going to be what research needs to be done. Now, the first one, which I would suggest from your answer, is that we need to get better, you know, more precise phenotypic definitions of this illness. Absolutely.
I mean, the first thing I have been advocating, me being in the field of public health and epidemiology, is actually just measuring it, quantifying it. The anecdotes are plenty. You know, so the Facebook group, the support Facebook group on its own for the UK, has got 32,000 people. You know, and same in other countries, in the US and many other countries. There seems we're not quantifying it as we're quantifying the number of positive tests and the number of deaths and, you know, hospital admission. So that's the first thing. And then obviously, you know, understanding what's happening, and it is a challenge because it is a wide variety of symptom. I mean, the overall, most people have this some sort of fatigue or, you know, post-exertional malaise, whether it's triggered by something or, you know, not knowing what it's triggered by. And as I said, cognitive dysfunction, things like poor concentration, memory problem, language problem solving, and what people really are calling brain fog. And again, that's depending on what people mean by it, seems to be a prominent symptom. But also, I mean, fortunately, I didn't so much have the cognitive symptoms, but I mainly had the kind of chest, you know, that chest heaviness, you know, palpitations, the fatigue and the muscle ache, you know, come and go throughout the illness. So yeah, we need. So it's great to hear the mechanism. Obviously, there are very plausible biological mechanisms, but I would like to add in long COVID as well. So there's the stress of the whole pandemic and the lockdown, but people with long COVID, there is the actual anxiety of not being recognized by, you know, by healthcare, because what is this? You know, people were turning up to their GPs, the GPs are not recognizing these chronic effects and nothing happening. So that really increased the anxiety, just the recognition, you know, of long COVID, but also the anxiety of what's going to happen. Nobody can tell you a story. What is your chance of recovering? Nobody knows. So, you know, that worrying aspect. So again, it's multifactorial.
Well, this question, what is going to happen, of course, when we want to predict the future, very often history can give us some answers. So this really brings me over to John. I know at the beginning of this pandemic, I seemed to receive a lot of emails which referred to this unprecedented situation. Now, I wish it were unprecedented, but in fact, epidemic disease is extremely well precedented in history. What insights can the history of pandemic disease give us into the current situation which we're experiencing?
Well, without going too far back in time to the plague of Justinian and that sort of thing, I think the first well-characterized pandemic in the modern era was the flu of 1918. But our world has changed so much since then that I do wonder what lessons that actually teaches us. So that was a disease that spread over several years. Actually, it probably started sometime in 1917, didn't really fizzle out until about 1921. It spread by road, rail, and ship. And of course, there were neurological consequences for a subset of patients, well recorded. Perhaps the lesson that we could take from that is that pandemics go out with a whimper rather than a bang. I mean, the disease gradually fizzled away. even though it's almost certain that full herd immunity wasn't established. So I think we probably have to move into the 21st century before we have lessons which are really relevant to today. From SARS in 2003, I think we learnt the importance of non-pharmaceutical interventions. I mean, that was a disease where there were no treatments. The vaccines didn't appear, but it was dealt with. Fortunately, it didn't spread very well, not nearly as well as the current coronavirus. So it was dealt with by non-pharmaceutical interventions, but particularly contact tracing and isolation. But perhaps lessons which we have learned and we are applying now come from the flu pandemic in 2009 and from Ebola in West Africa, which wasn't a pandemic, but it taught us a lot about how to do research. The clinical trials in 2009 were really slow to get off the ground, really slow. I think there was barely any that started while there was enough cases around in 2009 to have to be able to measure a difference between interventions and no interventions. And similarly in Ebola in West Africa, the only randomized trial which produced a result was the vaccine trial. Which has subsequently become a licensed vaccine. So that led to a lot of work on how to have kind of template off the shelf research protocols ready, and those have been applied. Those have been applied remarkably quickly in the case of the pandemic we're going through now, with such things as the recovery trial and the remap cap trial and the solidarity trial coordinated by the WHO. So we have, I think we've learned lessons in how to investigate a pandemic. I'm not sure that we've really learned many lessons in how to stop a pandemic from becoming a pandemic.
Right, so with that in mind, that what we've learned seems to be more how to learn things, how to research the various important questions of the pandemic. I'd like to turn again to Ed. Now, from your point of view, what research needs to be done to determine these precise mechanisms of the virus and its impact in the short term, as Max has been talking about, and in the longer term, as Nisreen has described?
Yeah. Well, I mean, there certainly is more work to be done experimentally with animal models to understand details of mechanism. One mechanism that's much discussed is this concept of neurotropism, that the virus can invade the nervous system through peripheral sensory receptors and then track back through nerve fibers to reach the brain. And we can see this in animals. It could account for the loss of taste, the loss of smell that we see clinically. That could indicate sensory receptor infection in humans. And of course, we need to understand those mechanisms more deeply. But I think given where we are, the focus of research should be very much on the clinical side of things. And as with all clinical research, it boils down to better understanding and better treatment. In terms of understanding, you know, we need biomarkers. We need to know what evidence is there from brain imaging, for example, of injury to the brain structurally or functionally or biochemically. We need, particularly with the importance of the immune response in mind as a possible causal mechanism, we need to know what signatures of the peripheral immune system can we read off from a blood test that might indicate high risk of brain injury. And you know, there will be other markers that need to be developed. For example, cerebrospinal fluid can give us insights into molecular and cellular changes in the brain that are otherwise very difficult to access from living patients. All of this is still at a fairly early stage. But to John's point, I think he's right. One of the things that I think we have learned is that in response to pandemic, you have to move fast. The research community has to get organized fast. And I think one of the really encouraging things about the response to COVID so far has been the tremendous sort of collaborative energy in the research community worldwide and in this country, which has enabled things to come together and get going faster than I've ever experienced in my pre-COVID research career. And just to highlight a couple of those developments in this country, there's already a large post-hospitalization research consortium called FOSP or Seymour, which has reported some imaging changes, brain imaging changes in about 40 or 50 patients after their hospitalization for COVID. That's a really remarkably rapid result, and it sets the scene for CNS COVID, which is another national consortium that was funded by the government back in October. And that is again a national collaboration, and I'm happy to be part of that. And it's really exciting to see how quickly we've been able to get that going, so that we hope in February we will begin to recruit the first post-COVID patients for very detailed imaging, biomarker, cognitive and mental health assessments. So I think some of what needs to be done has already been done in terms of understanding biomarkers in clinical cases. We need more biological work to understand the mechanisms, and then of course we need to look at treatments and interventions. And I think some of that could be pharmaceutical. We've already seen anti-inflammatory drugs like dexamethasone and tocilizumab being repurposed for COVID. I think we need to understand, is that relevant also to the mental health and neurological aspects of COVID? Are there other anti-inflammatory or other drugs out there that could be repurposed? I think we need to think about prevention of the mental health and neurological consequences. I mean, the vaccines are fantastic, but I think, have very little insight yet into whether they're protective against the mental health consequences of infection or neurological complications of infection. I think there's a lot of work still to do there. And I think also that interventions for mental health, even in those cases where we think there's a biological root cause, need not necessarily be biological interventions. I think the role of digital interventions, retraining, particularly to Nisreen's point about brain fog and cognitive impairment, there might be a lot that could be done digitally to help people recover normal cognitive function, even if the root cause of that brain fog in the first place was biological rather than psychological. So tremendous amount still to do, but I think it has been very encouraging to see the speed and energy and collaborative spirit with which people have got started.
Thanks, Ed. Now, just a reminder to anyone watching, if you would like to ask our panel any questions, you can put them in the chat box, and we'll have time for those questions in just a few minutes. But I'd like to move now from the biological, if you like, to the social and back to Max. We touched on this a bit before, and I'd like to go a bit deeper into it. How might the current social situation, the discourse in the media, how might these affect people's response to contracting this illness?
Well, yes, I think as we were discussing, there might be a biological explanation and there might be a psychological explanation that links COVID to subsequent mental illness. And if we focus on the psychological response, I think we would probably agree that a large part of that explanation is played by how anxious people get when they get COVID. Many people would fear that they might be dying from COVID, and indeed some people do die from COVID, and because of that it's quite a stressful condition to have. But many people would have relatively mild illness with COVID, and it would be quite interesting to see, and I don't think we've got the data for that, but to see how that response has changed over the pandemic as sort of the message has changed from the very early days when there were a lot of people saying, well, this is just a flu, this is nothing to worry about, to the sort of later stage to now, when a stage when we have some treatment, we start having a vaccine, etc. When the response might have changed along those lines. And I think we've got data to actually comment on that. But certainly, when it comes to the psychological aspect of the link between COVID and mental health, I think there's got to be some influence of the media discourse and the social situation.
And I suppose this leads me back to Nisreen, that the public health response to this pandemic is probably the thing which is uppermost in most people's mind at the moment, the provision of lockdowns and self-isolation and testing and so on. But I wonder how mental health sciences could possibly add to this public health response, whether it's in terms of informing messaging or whether it's in terms of assessing impact. What can the mental health sciences do?
Yeah, absolutely. I mean, from a public health point of view, the mental health burden is huge. So, Ed mentioned obviously phosphanol, the kind of research going on, but I think it's important to remember that most people infected with COVID weren't hospitalized. So obviously we're hoping that there'll be more research and people, non-hospitalized. But I think the estimates now, so this is a direct effect I'm talking about, the direct effect, which is obviously for people who are living the indirect effects as well. But the estimates from the ONS is about, at least a conservative estimate is 10% of all infections will still be unwell 3 months on from the infection. It's a huge, huge, and with the numbers that we're having in the last 7 days, we had 400,000 confirmed infection, and the ONS estimates over 1 million really over a week. So 10% of that is huge. So I think this is a big public health burden, but also the indirect effect. I mean, for example, with long COVID, I've always advocated that we need to, because it's so, we don't understand it, we need to measure recovery. And actually this is quite difficult because hardly anybody went back to their pre-COVID lives, so including all the mental health effects and the anxiety and all of that. One big feature I just want to highlight for both effects, the direct from having COVID and the indirect from the pandemic response, is the huge inequalities. Disadvantaged people tend to suffer the most because they're more exposed, they're more likely to get COVID, they're more likely to get the mental health effects of it. Also, they are more likely to not get adequate care and recognition and the investigations they need, and get adequate sick pay, etc. So I think we need to understand that, and we need to understand the social factors determining that as well, and work together in terms of the mental health and public health and everybody else.
Thank you. And this really leads me to John. One of my problems with mental health, and this is something when I was working as a psychiatrist, and it's something which I found in the research world as well, is that mental health is still, I think, kept very separate from the mainstream of medicine. There's psychiatry and then there's everything else. How can mental health be successfully integrated into the research and into the clinical response to this pandemic?
Yes, great question. Well, having lauded the efforts to have clinical trials off the ground quickly through having protocols and templates prepared, the respiratory physicians and the ID docs and the epidemiologists who put together those protocols weren't thinking about mental health. And a lesson that we've that is abundantly clear over the last year is that next time round, and there will be a next time, is the next time round we need to be ready to ask those questions, to characterize the mental health effects, and to be ready to intervene in them from day one, and not leave it as an afterthought.
Thank you. Now, I'm just going to move to the questions now. We've had a couple of questions in. Please do keep sending them. Now, this person asks, how are community mental health practitioners locally and globally coping with the impact of huge numbers of patients who need urgent treatment in their homes, as they cannot access face-to-face services during the COVID-19 pandemic lockdown? And I think that this question really goes to the issue of service provision. Now, the big change which I've noticed in mental health over the past 10 months has been the digital mental health, which we talked about for a very long time beforehand, and we're sort of more or less running on the spot, has really taken off. It's been something which has been put into practice, has been put into action over the past 6 months, especially in a way it never was in the previous decade. So I'd like to hear, I mean, Ed, you were talking about the possibility of digital interventions, maybe even to counter some of the more neurological effects of the virus. I wonder if you could tell us a bit more about that.
Yeah, I mean, I think digital is going to be crucial for dealing with the effects of COVID, but also dealing with the post-COVID environment for mental health generally. I mean, it's a funny thing, we tracked demand for mental health services very closely in Cambridge during the time of the first lockdown. And what we found was that actually there was a marked drop-off in people seeking mental health services. And I think that mirrors what was reported in terms of people staying away from hospitals, not reporting physical health crises like heart attacks and strokes and so on. It seemed that in the immediate aftermath of the first advent of the pandemic, people just stayed away from health services in general. But certainly over the last 6 to 9 months, in the bit of the NHS that I see, there's been a dramatic ramp up in terms of various digital ways of intervening and assessing individuals. It's never going to completely substitute for face-to-face contact and face-to-face assessment, and some of that is going to have to continue. But I think, as you're implying, Neil, that you know, we talked about the digital revolution in mental health for quite a long time before COVID came along, and nothing much actually changed on the ground. And I think one potential upside of the COVID experience is it might have accelerated digital adoption by mental health services. And I think we'll find, even as the pandemic fizzles out, to use your expression, in time, we're not going to go back to where we were before, I don't think, in terms of mental health. I think that will have forced an enduring change in adoption of digital tools for various different disorders, both to assess and monitor symptoms, and also to intervene, to administer forms of psychotherapy online, or to provide self-help cognitive retraining programs. I think these are all opportunities for therapeutic advances that have in fact been accelerated by the crisis of the pandemic.
That's great. My one note of caution from the medical publishing point of view is that I've seen many more articles talking about the potentiality of digital services, or many more articles which are quite excited about what could happen, saying that intuitively it could replace these face-to-face conversations, but those have swamped the actual evidence. How, Nisreen, can we have evidence-based digital interventions? How can we collect this evidence? How can we analyze it? How can we refine interventions?
I mean, I think absolutely you're right, and I agree with that. There are many advantages. What you say, the evidence is important, but I think this applies to a lot of everything else we try to measure in public health. Is that it is likely, the hypothesis is there are some groups who will be very much disadvantaged by this, some groups who don't have the level of digital literacy or the access, to make use of this service, or there'll be barriers, and these are the groups who we always struggle to have the evidence for in terms of research, in terms of the participation. So in trials. So I think that's really crucial to understand that whatever evidence is generated, whether it's observational studies or randomized control trials for interventions, who are recruiting, the representation really of the sample, but that's always a challenge, and that's why I think having systems, using routine data is key, and having systems in place so we can collect the data and look at the evidence for the population as a whole.
So to use a cliche, it's about minimizing the unknown unknowns, minimizing the groups about which we know little, and doing this through systematically collecting data.
Absolutely. I mean, the term that is usually used is hard to reach, which really is not a very good term. I think it's more people on, I think it's the onus on us as researchers, as people working in public health, to actually to make sure whatever findings in the evidence we have would apply to them. And I think the way forward is to use this, systems. It's basically systems. Yeah.
Thank you. Now, the next question we have, I'm going to put to Max, which is, do we see specific effects in the age group of young adolescents?
So we haven't specifically looked at that, so I can't answer for certain. I think when it comes to, as Ed was quite nicely sort of separating, there's the biological effect, there's the psychological effect of having COVID, and then there's everything else related to the COVID-19 pandemic. And I think there's quite a lot of, or at least growing evidence of the latter impact on adolescents in particular and young adults, with the fact that schools get closed, etc., that their social life gets completely disrupted at a time where it's probably very important. And so I think in the latter part, there's I think strong and growing evidence that that COVID-19 will have had a high effect. But I don't know about the direct effect of COVID itself, of getting COVID on that population. I don't know if anybody does.
Can you add anything about this? I mean, in general, it seems that in terms of the actual biological effects of this virus, the young are comparatively safe. But do you have anything to add on that? Oh, you need to unmute yourself, of course.
Yes, of course I do. Well, I could observe my own children. I mean, I do have a adolescent. I have my oldest daughter is actually working in the health service, and she's giving vaccine, and she is actually rather energized by the whole thing. In that she sees that she is now a frontline. She keeps saying, "I'm making history, aren't I?" So for her, I think it's almost the time of her life in a way. And then I've got a 17-year-old daughter who has been through the whole cycle of anxiety, depression, uncertainty, the lack of socializing, concern over her exams, which are going to be cancelled again for a second time. And then a 9-year-old daughter who has been to school for 1 and a bit complete terms in the last year, and she is bored out of her mind. Now, on the purely virological side, yes, young people are remarkably, compared with flu, for example, they are remarkably free from serious disease and death from this virus. I like the way that David Spiegelhalter put it a long time ago, right at the beginning of the pandemic, is that the virus roughly doubles your risk of dying in any given year. So if your risk of dying as a 9-year-old child, which is effectively zero, is if it doubles that, that's still zero. But if you're an 80-year-old person, where your risk of dying in the next year is about 15%, then that doubles it to 30%. So I mean that's a nice way that I kind of encapsulate the age difference. But I think, coming back to the purely mental health aspect, we are going to need to be very careful to monitor the health of our children who have gone through a restriction in their social interaction, in their schooling, which we have never experienced before.
Yes, I mean, this is something. Sorry, Nisreen, go ahead.
I was just going to say, absolutely, I agree, and I think it's really interesting. It's the restrictions and it's the mental strain and how they react to it. I mean, I've got two teenage. Well, I've got 3 really, 1 in primary school and 2 teenage, and they react really differently. You know, one tries to kind of shut it all out, even though everything's happening, but and the other one is almost, you know, obsessed by, you know, trying not to transmit the virus and all of that. And I have a friend who has another, you know, teenager who is probably, you know, having mental health, you know, issues and stress because she lives in a multi-generational household with her grandparents and she was going to school. So I think the stress levels are huge. That adding to that, you know, the school and the exams and, you know, cancelling and all of that. So I think, yeah, absolutely, it needs to be monitored. It's such a difficult. So I think although we say children are not affected biologically, they don't live in a separate bubble. They live with other people, and these other people are affected in one way or another, you know, in households. So, yeah.
And if there's one thing which the psychological, neurological sciences have taught us about adolescents over the last 20 years. It's that socializing is what their brains are trying to do at that particular stage of development, and we need to be very mindful of the consequences of lockdown on that aspect of their lives. Now, I have a very, very specific biological question, which I'd like to just put to Ed, and that is, will genome sequencing help us better understand how the virus affects mental health?
Well, I think genome sequencing has already helped us understand a lot about the pandemic. And I think it's one of the things that's been very strong actually about the UK response in terms of research is the large-scale genome sequencing. I mean, what the impact of new variant versus old variant is on, let's say, neurotropism. Does it make the virus more or less likely to get into the brain? Does it make the virus more or less likely to trigger an immune response which might have adverse effects on the brain? We simply don't know. But I think what we have learned is that variants can make a big difference, and it's wise to be vigilant. And it's certainly an angle that we'll need to keep thinking about. But as far as I'm aware, there is no evidence yet that the genetic variants that we've seen so far make any difference to the likely impact directly of the virus on the brain. But it's something that could happen and something to watch out for in future.
Thank you. Now, John, yes.
I just make a point on that, is that genome sequencing is one of those things that we've been publishing on for 10, 20 years or so. And it's all been it's always seemed a little bit of a luxury, you know, a sort of nice to know, but what does this actually mean? And suddenly, in the past few months, it's really started to mean something. And it does show in the midst of all the gloom how we do have the tools to respond in a way that we simply didn't have at the end of the last century.
Which leads me very nicely to the Roundup question. Now, people who've been watching these webinars for a while will know that we normally end these sessions with a single question, the answer to which must be given in 280 characters or less. And the question I'd like to put to our panelists this time, starting with Ed, is what is the #1 research priority right now with regard to the mental health effects of the pandemic?
Don't get forgotten. Mental health must not get forgotten. Don't get split off. Don't have mental health researched in a silo separate from physical health, because as we've heard from Nisreen, particularly with long COVID, you know, there's a complex mixture of physical and mental, and we need to think about the patient altogether rather than siloing it off into separate traditional specialties. And the third thing is we need to be in it for the long game. You know, I mean, long COVID, we've heard about the educational impacts, we've heard about the unknown consequences for adolescent development, we've discussed. All of this means we need to keep a watchful eye and be thinking very actively about researching the mental health consequences of COVID for some time to come.
Thank you. Max?
I think that therapeutics is very important. We sort of start to establish that there's going to be mental health consequences. We need to know how to treat them. It might be that we treat them exactly as we treat mental illness without COVID, but it might be that there might be specifics about COVID that create some opportunities, that create some challenges as well. It might be that, as we've alluded to earlier, that some treatment for COVID or for complication of COVID might help with the mental health consequences. And it might also be that some treatment for mental health, and we've seen some evidence that some SSRIs, which are usually used to treat anxiety and depression, might also be useful to prevent the adverse consequences of COVID. So I think that's the #1 priority, is to better establish that.
Thank you. Nisreen?
Yes, I would first non-separation of the physical and mental health research. That's really, COVID is an example, but that is an ongoing thing that we see all the time. The other thing is, the other thing I say, please don't, that this pandemic has been horrendous for all of us. It's been much more horrendous for people who are already suffering before the pandemic. You know, the effects are devastating, and we really shouldn't, in research and generating evidence, shouldn't ever forget these disadvantaged groups, because whatever we generate might not apply to them, and actually could be that we're widening inequalities by, you know, by some sorts of evidence.
Thank you. Finally, John.
Yeah, it's something very specific, which pops into my inbox every now and again, and I find deeply confusing is the very debilitating disease of chronic fatigue syndrome, which has a neurological and a mental health component. Is it possible that the intense and there will be intense research into the biology of long COVID will at last lead to some insights into the causes and management of chronic fatigue syndrome?
Thanks. So the message, I think, is that we've got to work together, and we're all in this for the long haul. Thank you very much to all of our panel. Unfortunately, that's all that we've got time for. I'd also like to thank all of you who are watching online for joining us and for your very thoughtful questions. Now, as I mentioned at the beginning of this session, you can continue the discussion on Twitter using the hashtag MH4All. And please do join us again in 2 weeks' time for our next webinar. The details of that will be up on the United for Global Mental Health site before too long, as will. So I hope you'll join us again next time. But for now, goodbye.
Bye.
Bye.
Right.